be torture. It's going to be fun. And you need to do some introduction or we're ready. Okay, that's great. So we ready?
We're ready if you're ready.
Okay, well, I'm ready. So we have some people moving. So I will tell you a little bit about me. First of all, thank you, Mark, Jose, Dr. Sanders, Barb, and everybody in the Summer Institute of Aging. I have been working with them for several years. I'm Liliana Oaks. I'm a geriatrician and a palliative care physician. I am Colombian, so if I'm talking too fast, you just do this, because I get excited and then my accent can be tricky on you. I spent 10 years in the Health Science Center as a professor, and I switched gears in December, and I decided to go into a wonderful venture with WellMed, doing a terrific project in palliative care in geriatrics and the home of elders, and doing palliative care to improve the care of people with serious illness. I remain part of the Health Science Center as an adjunct clinical professor, and I used to run the fellowship here, so I know many of you that do a wonderful job every day. So I always like to know who is talking, who is interacting with me today. So let us raise your hand if you are a social worker. Okay, I know some of you. Chaplains, therapists. Okay, very good. Physicians, interns, any other profession that I didn't mention? Case workers, nurses, or nurses. I usually start with that. Tons of nurses. Those are our right hand. What we will do without nurses. Oh my gosh. See, the sick won't heal. I can promise you that. So I'm going to walk you through something that is relevant to all of us. How many of you have had a relative that is elderly being hospitalized? How many of you care for somebody that is frail or elderly? Or know somebody in your neighborhood that you actually check on? Okay, all of us have a business or interest in geriatrics because that's the new. More walkers than strollers. Japan is selling for the first time diapers, adult diapers than children diapers. That is our new reality. So I wanted that you put your glasses today about, can we do a better job when they get hospitalized? Unfortunately, our goal will be that people do not go to the hospital, that they stay home, that they remain functional, but they sometimes need that care. And I think we have a lot of work to do. That's why we're going to spend 55 minutes. We're going to talk a little bit about why this is important and how the healthcare reform and all the changes in the country are encouraging teams in hospitals to do a better job about that. We're going to talk about a little bit about the transitions of care, and we're going to go about 10 things that we can do better when a patient gets hospitalized. How many of you do hospital work currently? Or work in a hospital? In a skilled facility? Okay, so the majority of you. If you don't, it's very relevant too, because you're going to be on the other end when they go to the clinic, when they are in the clinic and you need to send them to the hospital. What do you tell the caregivers? How you coach families to cope with these hospitalizations? And then we're going to talk a little bit about resources that can help you to think in terms of improvement. Never get stagnant into, oh, we cannot change this, oh, the system is too big, oh, the bureaucracy. I think the heart should be, what can I do in my local environment every day so we can do a better job? That's what all of us need to be thinking about, wherever you are, clinic, hospital, nursing home, or hospital. So these are scenarios, and probably they look familiar to you. 85-year-old Fred Elder is coming to the emergency department with acute mental status changes. Takes 10 hours to get admitted to the floor, and they get admitted at 2 or 3 a.m. in the morning, and everybody is upset because the patient is agitated, is screaming, there are no medications. 90-year-old admitted to the hospital, third time in 30 days. What is happening, right? 83-year-old discharged from the hospital arrives at the steel facility on Friday. I hate this. This is one of the scenarios that I hate the most. 9 p.m. No discharge summary. EMS forgot to get the package out, so no medications and no family member. And good luck, because you are in that shift taking care of this older adult. 73-year-old very demented male is admitted, no family, very combative. How you handle this? So have you seen the scenarios like that? All of us, right? Well, this shouldn't happen. And I think all of us are in the business business of, can we do something different, right? Can we improve the care in a way, and how that will look, we will see. What are the challenges? Older Americans account for 13% of the population. They are over a third, sometimes a half, depending on the area where you live, that are going to the hospital. There are approximately half of all the hospital discharges, and there is a high utilization of resources in the last 6 months of life. So this is the data. For the people that are dying in these trajectories of palliative care and that are in terminal illness, and there are around 25% of Medicare recipients, they're utilizing 75% of the resources. Very little group, very sick, using all the money. So you don't need to be an accountant to say, why is that happening? We need to do something better. And you have learned this entire week about multiple ways to decrease costs, multiple ways to keep people at home, multiple ways to partner. And I think that that's what we need to start thinking globally, is collaborations, opportunities, how we get part of committees to improve the care of the seniors. And we have also different expectations. How many of you carry an iPhone? Or a smartphone? I'm sorry, a smartphone, Android, or... Don't be shy, raise your hand, I wanted to see. Okay. Who is still the dinosaur that uses these Nokias that nobody knows? Okay, it's okay, we forgive you. It's all right. But what I'm saying is, are you in the restaurant and somebody asks you a question and let us ask Google? Well, right? Isn't that or Wikipedia? That's what the baby boomers are doing. The doctor told me I need to take this pill. Let me see this pill. What is this pill about it? Well, this Dr. Oz or Dr. whatever are in the market right now said that if I take this pill, I'm going to lose 100 pounds and I don't need to exercise. So that's what we are against too, right? The instant solution, the social media, and so, you know, the prior speaker was talking about the visually impaired, but it applies to, we have a culture that has expectations that are very unrealistic, right? And that makes the care a little bit more challenging. Well, you know, in Grey's Anatomy, she dies, they do CPR, and the next day she's kissing her loved one. You kidding me? My patients are like, but you see the TV and they survive and they talk after, you know, like, oh my gosh. God help us here. So that's what we are against, right? So we need to understand that it's more challenging. People have this information and sometimes it's not the best information. So we are in, I think, challenging times, but great and full of opportunities. And I think that that's how we need to see it. There is a lot of data since 2008 that we need to improve medical errors, right? And we are still making changes to standardized processes, to do the same things with the best practices, because when we know that we can improve the care, elders have less poor outcomes. We have a lot of more older adults. There are not a lot of geriatricians needed palliative care physicians, so we need to empower you. You know, we need to empower nurses or social workers or therapists to think geriatric, to think about what makes an older adult different and how you need to bring the families. And right now, mainly as hospitalists. You know, this model of all doctors doing everything is very rare. So again, how we train and partner better with these hospitalists that are caring for these seniors. This is a slide to point just that 1/5 of the 12 million Medicare recipients that was reviewed in 2003, 2004 by Janks. This article is the one that brought a lot of heat into healthcare reform, because we were investing a lot of resources and doing really poor care in the way that we were handling elders. And many of them were re-hospitalized in 30 days. What do you guys think are the causes for people to be readmitted in 30 days for the same diagnosis? Like one of those cases, you know, 90-year-old lady gets admitted for the 3rd time for congestive heart failure. What could be some causes of it? Yes?
Lack of compliance with medications.
That's huge. Lack of compliance with medications. So in our program right now in WellMed, when a patient gets discharged, there is a rule of 72 hours. The patient must be seen to do one of those components. Check their meds. And I can show you pictures of how the patients are in delirium or they're very sick. They get all of these long instructions, and then they go home and they don't remember. So they have duplication of medication. They take warfarin and Coumadin. They take 3 blood pressure pills, and they don't know exactly which one they need to take. because when they get home, they have new meds on top of the old meds, and then in the hospital, they change the inhaler because it's cheaper at the hospital with the inhaler, so now they have 4 inhalers, all of them different color, so they pick the color that they feel like that morning to use, right? Color code, I think that's an interesting proposal. But what I'm saying is that's a big issue. They usually return because they maybe didn't have the right medication, so they're taking too much. What else can make them being readmitted?
You don't have a lot of caregiver support.
What about, excellent, no caregiver support. So they go back home and we're taking probably around 50% of the elders in our program right now in WellMed live alone. And you go into their homes and you're like, oh my gosh, how they're making it. They barely have food, they cannot drive, but now we give them 3 new meds. Who's going to pick them up? Some pharmacies deliver, some others don't. And some of them charge $10 for the delivery. Well, $10, that is the milk and some rice of the medication. Do I eat or I pay the medication? So again, there are very serious issues in discharge. So wonderful. There are more reasons, and we will have the chance to talk a little bit in a case in a second. So 50% didn't have a follow-up visit between being discharged and at home. That was a major thing that the country is changing. All of this rule of being seen in 72 hours, many people are adopting it. Getting these people seen right away to see the medication, the social support. Do we need a social worker? Are they having needs for therapy? Are they functionally active enough to even go to the bathroom and toilet? Or they're going to fall down and now break the hip? You know, see, I mean, it's a sequence of events. Diagnosis that were common is what you see in everywhere. Your clinics, your inpatient services, your skill, heart failure, pneumonia, COPD, GI problems. And the ones that have surgery usually return not because of the surgical problem, but for a medical reason. Lady broke the knee or the hip, goes on, nobody is moving her, patient is not hydrating, boom, gets a pneumonia, gets sicker, goes back. So it's a cycle that we're trying to break using different models. And again, after you have been hospitalized, you got a lot of chances you're going to be re-hospitalized. So that's something to keep in mind. There are a lot of transitions of care. Some of you mentioned some of those. So there are fiscal pressures to decrease hospital length of stay. Do you know at this point more or less how much it costs per day in a medical ward to keep a patient? Okay, give me a number. 2,000. Here. 5,000.
3,000.
3,000. So around 28 to 3,000 per day. That's not ICU. And a skill is costing around $450 a day. So what do you think you wanted to get them out quickly? It's a big difference, right? So the DRG, the case manager, you're saying, doctor, can we do something else? Thinking about discharge upon admission, you know, social support, if this patient have enough money, who we can send them to comply with meds. There is a lack of healthcare continuity. So again, President Obama wanted to introduce electronic medical records. Awesome idea. The problem is right now in the city we have 10 different hospital medical records that don't talk among each other. So again, the idea is good, but when you implement it, and then now the nursing homes by next year need to have EMRs, they're going to be deemed in January 2015 if you don't have useful, meaningful use of EMRs. But now we have 69 facilities in San Antonio with 69 different medical records. You see how it's contradictory? You know, you wanted to do something, but on the other hand, they don't talk, so it can be a challenge. Medication is huge, and some of you mentioned that. Lack of preparation for patient or family. Again, how we talk to a patient, we're discharging them and the patient is confused or doesn't have a caregiver. Are we wasting our time? Should we rethink how we are? That's the reason the 72-hour visit, when the patient is a little bit better, the caregiver is present, you know, can improve compliance versus, well, this is the checklist, I need to get you out. Good luck. Community resources, lack of communication. Availability of discharge summaries. The idea with the EMR is that we hopefully start getting a little bit more, but look at that. Availability of discharge summary depends on your market, can be as low as 12%. I can tell you that there are markets where I have worked with 0%, meaning I never get a discharge summary. So now it's getting a little bit better, but I think 34% is still pretty low, you know, especially if it's your mom. You want, if it's your mom or your relative, that's how I see my patients, you want the best care, you want the best communication, and it's not happening. The problem also with the hospitals and the hazards is Usually we take a functional person that get acutely ill, and this is usually what we do to them. And we need to think in terms of changing this paradigm of care. We cannot put them in the bed. We actually don't call them by their name, but bed number 4, bed number 5. I always have refused to talk with my nurses about numbers. I just consciously make the decision that if they wanted to refer to somebody, they need to tell me Mr. Gonzalez, Ms. Jimenez, Mr. Smith. I hate when they said patient in number 5 or number 2. I just culturally, for me, that's horrible. I don't want it to be number 3 when I get admitted. Do we do it because we're mad? No. We do it because HIPAA, right? HIPAA. Well, so how we balance that, you need to make that decision. But we the personalized people, we give them ugly gowns. Any of you will love to buy the gowns from the hospital? And what about the booties, anti-slippery? They are horrendous. Again, that's what we use, but you see my point? And what about giving a Mexican-American asparagus? And, and the patient is not eating. Well, they never have eaten that food, but we give them what they don't need. You see my point? So the hospitals become very difficult places to think that a patient is actually going to go better. No, they do bad. And then we tell them, don't move, don't get up. So the best models of care are rethinking this. So I give you an example. The acute care of elderly unit in California is Dr. Pelusi has 23 different ethnic groups that they admit in their acute care of elderly unit. Because they're in the West Coast, they have people from the Philippines, China, Taiwan, Somalis. Well, they decided to remove hospital diets, and they just tell the families to bring the diets. They work with the families, they decrease a little bit the salt, but everybody eats what they love to eat. Versus everybody will eat asparagus with chicken, whatever American diet we put. I hate chicken, by the way, that's the reason I always eat chicken. But you see my point? So they liberalize the diet, and they ask the elders that if they're not infectious to others, they get up and they eat in a table. And if it takes 3 nurses to toilet them, but they were toileting before, that's what you do, you toilet them. You just don't give them a pan under. Because that is telling them, well, you're not being like a baby. So you see, it's changing the culture. It's really assuming a role of, we maybe will take more resources and a little bit more time, but are we doing the right thing for the patient? Are we moving them? Are we telling them to talk and doing cognitive stimulation? And if they like novelas, we play novelas. If they like to watch the sports game, talking about that. Because we know now that a lot of things get prevented when we do cognitive stimulation. Right? Versus putting them in the bed, new environment, cognitively impaired, then we put them in restraint, then we need to call for the Haldor, the risperidone, and then the patient having pressure sores and urinating, and the cycle needs to be broken. And that's what happened. We produce depressed mood, negative expectations, physical impairment, and from what it should be preventable is indeed disaster. So can we do better? Absolutely. New models of care are really heavily into quality improvement. Nurses, therapists, chaplains, social workers, nurses, physicians getting together, even the housekeeper, how we do processes where a patient can be better in multiple ways, from the functional status or advanced care planning or pain management. Anything that you could think we could do better is what the country is moving for. So you have here all of these words. You will probably go to a lot of meetings. Quality control, quality assessment. Well, when they work well, they are intended to prevent the horrible cycle that we just saw. That's the whole purpose. And these are, it's a complicated slide to show you how we are learning for industries like Toyota, the industry of aviation, where they all the time wanted to decrease risk. They wanted to decrease crashes in the airplane. They wanted to have perfect engines. And Toyota always have been recognized as having one of the best lean processes. And they love when an engine doesn't work because they don't see it as a problem. They see it as an opportunity. Well, healthcare is finally, we start to think about those. Where we remove waste, where we brought bureaucracy, where we can decrease giving the wrong medication by using the appropriate color coding, rechecking those bracelets 3 times, marking the appropriate leg so you don't amputate the leg that is. All of that is coming from other industries that have taken seriously that. And everybody that has get into the best models of care in medicine has chosen to do safety culture using technology, applying evidence-based practices and process of standardization. So another example is Baptist has the best knee replacement program in the city. You know how they did that? Does anybody read that in the news? So they got all the surgeons, big surgeons, I don't know how surgeons are. Each one operates, they train in Hopkins or here or whatever, and they choose this knee replacement titanium thing, the other one was using another one. And they start thinking, seeing the outcomes, and all of the outcomes were different. And they start looking into which ones have the less amount of time in the procedure, the least complications, and what device was placed in their knees. And they discovered that if they use the same device in all the patients, the cost immediately decreases because you are ordering one device versus 10 devices that have different costs. And they agreed to standardize their surgical from where they put the patient to sleep, cutting it, replacing it, and closing. And they have the best program. Everybody agreed to standardize. Best procedure, best practice, best device, decreased cost, infection rates went down, patient satisfaction went up. So that's what we're looking. That's an example of how are going to be providing services, wherever you are, in terms of pain management, delivering protocols for ICU and ventilation, that there is great data on that, that when you standardize the settings and ventilate in the ventilator patients in the ICU, you decrease nosocomial infections. So again, that's where we are going, and we need to catch up because Texas is not exactly doing the great job. This is one of my mentors, Mike Malone, has the best acute care elderly model in the country. Aurora, Wisconsin, if you wanted to take a trip and be amazed of how standardization, best practices, and geriatric hospitals work, go. It's worth of a trip. They have a conference every year called the ACE National Conference in November. Fabulous model. We have one that I replicated when I was in the Health Science Center here in Cristo Santa Rosa. You can visit that one, ask for a tour. Some of you have been there. And the idea is that you're looking into how you integrate complexity between the ACE teams, doing daily huddle, discharge planning meeting, communicate with your partners, go with the long-term care, the PCPs, how you implement in the nursing home programs that are standard of care like Interact, that stands for interventions to reduce acute care transfers, which is a national model of Medicare now to decrease readmission rate. So now let us work a little bit, get somebody next to you, behind you, whatever is comfortable. And this is the case of the day, and we're going to be working for the next 20 minutes to see some of those. If I cannot review all of them, you have the slides. But I wanted that you learn about this patient. She's Josefina, she's 77 years old, she's Spanish speaking. She got familiar with history of diabetes, kidney problem due to the diabetes. She got already tingling hands and feet, she got neuropathy and high blood pressure. She was in the emergency department for confusion in the morning. The emergency department says, well, she got a UTI, they put a folate. She was admitted by 11 p.m. More history is gathered because the Spanish interpreter wasn't available earlier. And now the patient, the caregiver says, well, she has been falling frequently and has been confused over the past 3 days. She gets from bed at night after receiving hypnotics and falls and she breaks the heel. So I wanted that you, for 2 minutes, make a list of everything that is wrong with that scenario, and you're going to be sitting in a committee where the hospital is inviting you to say, you are the expert consultants from your discipline. What can we do better? So find the problem and make a suggestion of how you think this disaster could have been avoided. So you have 2 minutes, go. 2 minutes to fix the world.
Our work dresses recently.
Yeah. Which is I'm going to go out.
history of versus celebrating where we help patients with suffering. And it's called Rafa got and it's the first retreat that I'm part of. So we're going to be talking about helping change the way how you can help the person to the suffering. And I do that a lot with the patients. They start at 11. But it worked good that this person let me do it at 5.
Yeah, and you don't want to wear the same thing. Right.
It's pretty dry. From the medical perspective, I can talk about pain interacts and affects so much physical pain, which is what we see psychosocial pain and advances in terms of it doesn't say how we cannot disconnect both, so I can do it from a medical perspective. Medical, we can do it. Oh, so we can look at two perspectives. You know that.
I heard you say my name, but I didn't get it all.
How's he doing?
He's doing great. That's where he was.
You need to have an interpreter.
He had some problems with his boss. He was not good at the check with school, but he's got a really some life, so he's all to do.
That's a big issue because it was public.
Okay, let's see who wins the world. I have, high expectations. Okay, what do you guys talk about? Who wants to tell us? No, you are the fellow. Fellows always talk first. That's the academic view. Okay, Sean, what do you guys talk here?
We were just talking about just the fact that she was brought in the morning, wasn't to a room until 11 o'clock, so had not eaten probably in all that time. Need a Spanish interpreter earlier on in the process. There's nobody there, just like her caregiver or family or support to help, give some history. Noticed that she has been taking medication that's probably contributing to these falls, so maybe that can be less, hypnotic medication.
Very good. Awesome. So a lot of points. What about you guys? The same. Wanted to add.
I figured that they should have had like a case manager or social worker involved earlier to try and get background information, some more collateral as to what's been going on. And since the morning, it doesn't tell what happened between the morning to the evening, so were there any labs? I mean, they only put a Foley in, they started with treatment.
What do you guys think about that Foley?
Not good.
Not good. Why is not good? Why Foleys are not good? Source of infection. That's a huge never event, right? If you put the inappropriate Foley and they get infected, that's not good. Isn't that interesting? It's the bad thing to do, but only became a never event until the hospitals needed to pay or swallow the cost. Isn't it that horrible? But every time you tag the packet or somebody, that's when people disconnect, which is okay with me. What else did you guys talk about here? That's the fellow. Awesome. Okay.
She looks older than the stated age. She doesn't have teeth. She looks frail. Don't have background information on caregiver. And why is she taking a hypnotic? Important history. And nutrition. Nutrition is a problem. Well, caregivers, I don't know about it.
But we don't know, but it's really hard because the interpreter wasn't available and then you hear, so again, more history.
But even if the interpreter was available, she is not a good historian, it doesn't appear.
Exactly. So likely she got a cognitive impairment, right? Well, this is the new America. These are the patients that we're seeing. And if you work in poor populations like the West Side where I am, I'm the doctor that goes to all the households in the Southeast and the Southwest. This is a typical patient. So again, you guys did a great job. There were several levels where there were problems. So some of you, what I'm hearing saying is, we need to look into her medications because we need to find out this was bad. We need to look about into what is the ER protocol to place Foley's. I always joke that every time that you go to university, you get a CT scan and a Foley catheter. I hope that the joke doesn't apply anymore, but that was what we did, when I was in training many years ago. It's like we're afraid. You put the CT scan of the head and a Foley catheter. Now we know nurses have protocols, and they actually are able to remove Foley's under the protocol without a doctor's order. I love those when we empower teams that don't depend into the doctor, and we just do it because it's the right thing to do. You also mentioned a lot of into the collateral history, getting involved people in your team. If it's only the ER doctor and that day all the nurses were busy that could interpret it, and there is, where is your case manager in that ER? So you work in that hospital, you probably can come with a list of very good questions for the CFO and the CEO and said, we really need to look into the ER processes. We really need to look about resource allocation and who is helping and what populations are they serving. Again, California, they have tremendous diversity in their team because they're serving 28 different ethnicities. So imagine they probably have people that speak 2 or 3 languages because it's the only way to do a good care with those elders. So a few things that we can learn. One, a culture of safety. Acknowledgement of the high-risk nature of the amount of things that we do for an elder. And if we really do not think in terms of every elder being at high risk, we're always going to be neglecting some. Second point, a blame-free environment. I really hope that you're changing the culture where anyone can stop and say, I think something is wrong, and don't be penalized for it. Like in the airplane, I hate when the airplane gets delayed or they get you out of because somebody detected a little light that should be in the airplane, right? And you get mad. Oh, I cannot go home. Would you like to die because somebody noticed it? Oh, it's a little blinking light. Isn't it that funny? So we really wanted to be safe in the airplane, but when it's the patient and there are 3 Rodriguez right now in my floor, and gosh, I'm exhausted, and I'm going to just run this antibiotic and this Rodriguez, and I didn't do all my bracelet check. And so that's what we need to say. Hey, stop. We have said even with the other nurses, let us stop and recheck the name. I think this person is not the right Rodriguez, and that person in the other nurse was like, oh, thank you. We almost delivered the wrong one. They embrace it. They cheer out. They are, housekeeper in my nursing home. She just very humble, little sweet lady, doesn't speak English. And she is mopping the floor, and I was rounding, and she came quick and said, Doctor, in Spanish, I'm sorry to tell you, but that lady was smiling at me yesterday, and she's tweaking, and I'm not a doctor, I'm not a nurse, something is wrong. And I immediately commented and said, let us go. The lady was evolving into a stroke. What do you think you do with a housekeeper like that? We gave her a little recognition. You bring her into the staff meeting, a stand-up meeting, recognize her, you embrace her. Versus, I'm so busy right now. Can somebody check later, and then the others check later, and then the lady is already past the 3 hours, nothing can be done. So a culture of safety is vital. How you praise the people that said, can I ask it? There are not stupid questions, there are never something that you could take 2 minutes to check on. Collaboration across ranks. So again, I really love, and I try to embrace that. You walk among your people that do the job. So I know the names of the housekeepers. I know the guy that does maintenance. Everybody owns the patient, encouraging them to own the patient. Know the lights. I'm the maintenance guy, so I only do like, no. A maintenance guy that come and notice that a patient is ready to fall is as responsible as a nurse that come into reposition. So again, how we are building our institutions, wherever we are, your clinic can have the same issue to do a safety culture. So what you can do to do that, teamwork training, executive walk around. That's when I tell people that are in the high rank to come and talk with the people that actually are in the front line. What is going on, what is working, what do you think we can do better, visiting with the patients, getting their hands dirty, unit-based safety teams, learning from what happened, checking that all the patients have the alarms on. We have some technology, but if you don't use the technology, it's worthless. You can have bed alarms, but if the bed alarm is not connected, does it work? No. So again, and I think the VA is doing a lot of into patient safety. Checklists and templates, especially in a surgical unit, protocol-driven, things like that. The stop the line concept. I think we're doing something wrong, we need to stop, and don't be afraid to say we need to stop. You know, we skip a process that has saved people in the OR. Second, recognize and tackle the never events. All of you know what never events are. Who can explain to me what a never event is? Well, nurses are champions in life. The fellow already talks, so. I need somebody else. They are so shy. What do you think a never event is? Or give me an example of a never event. Sometimes the example helps people.
Not reporting error.
So no reporting errors, things that shouldn't happen and we will get penalized for. So for example, those serious reportable events. So urinary tract infection because you place a Foley inappropriately. A patient that has preventable falls but they fall and break the hip, and then Medicare look into your hospital and say, that patient has a preventable fall. The patient break the hip, I'm not going to pay you back for the broken surgery. You swallow the cost. The same for the nursing home. Receiving the wrong antibiotic. There is tons and tons and tons of those. And they don't get reimbursed by Medicare. So that's the reason everybody since 2010 wanted to work together. You had your preferred list of nursing homes, your preferred list of home health agencies, your preferred hospices, because everybody is thinking in how we prevent all of those things, and now everybody's trying to integrate and work together. So this is the list. Surgery performing the wrong body part, surgery performing the wrong patient. All of those Medicare is saying, if you do that, we're not going to pay you because these things are preventable. Death of a serious disability associated with hypoglycemia, right? So somebody was mentioning, had she been eating since the morning? You know, and you don't have a toddler, what she's a diabetic with insulin. And then she's so confused because blood sugars are 23. So are we looking into all of those things, you know? So the list is you can talk to your patient safety coordinators, quality improvement nurses. They can really give you more information on that. So get expertise in quality improvement. So you're like, really, Dr. Rose is talking about that. I don't have a clue about the terminology. And there is a lot of great resources locally. So the idea that you define your aim, you work in teams, you do process mapping, you do cost effective. So if you wanted to get better on this and learn from that, you can get a course like here in the Health Science Center. It's called the Clinical and Safety Effectiveness course, and they take teams for 6 months. You choose a project that you wanted to get better at. You learn how to do it. You learn the terminology. You learn the tools to do the quality improvement, and you get a poster and a little publication if you want to. But most important of all, you do something great that can change your systems. So some nurses are working falls reduction. Some other teams are working delirium prevention, pain management, enhancing pain management, screening and management. And all of those comes from what you need to know about your organizations. Do you know what your organizations are lacking of? Do you know how your percentage are in infections, patient satisfaction, time of waiting, if you are working a clinic between arrival to when the patient is seen? So if you look around and start looking and you put glasses, you start seeing a lot of opportunities. Instead of just do the same monotonous job that can become a little bit bored, you can say, wow, patients are waiting 2 hours. Can we do something about decreasing that waiting time, right? And the ER the same. Well, falling, we maybe have a falling room. Maybe you have an area where everybody is falling. Advanced care planning, we work here with our team and the VA improving advanced care planning and the multi-specialty clinics. That was an issue and I think we're doing great, right? Pretty good. So everybody, they created videos and we have social workers that go and talk to their families. So opportunities, what is the opportunity? This is the course. These are some of colleagues I have taken. I was part of that, and I constantly am doing quality improvement, constantly checking what I am going to do, what we can do better, how we can remove things that are wasting time or they are bureaucracy, or how we can improve and streamline processes. This is big, and therapy can tell us, some of our therapies, why we need to move people early on from the physical therapy or occupational therapy. I know you're here. Why we need to move people?
So you can keep them active. If they're not active, then they're not active.
They need to be active. Who wants to feed themselves? Raise your hand. Or you wanted to be fed? Confess to me. Confess to me. Who wants to be toileted by somebody else? That's a big one, right? That's where patients feel their dignity so bad. I don't want my son to be that or my daughter. So we want them active. We wanted to enjoy life. We wanted to have an opportunity to engage in what is important to them. So we need to change the paradigm of bed rest. Poor you, you're sick. Yeah, they're sick. But it doesn't mean they cannot move. They cannot do some of the activities of daily living. And they cannot be cognitively stimulated by all the team. Simple stimulations such as, good morning, I'm Dr. Oaks. Can you tell me where you are? Do you remember why you're here? Tell me what you like to eat today. Tell me who is, just that. And if everybody in the team, every time they have an interaction, remind them, talk to them about the housekeeper. Look at that, Colombia passed to the next round in the World Cup. That's pretty stimulating. Now, if you're not Colombian, they're going to say, what? Well, U.S. also moved, so hey, you can move to U.S. So, you see what I mean? The point is, sometimes, I hate Jerry Springer. That's what UHS shows on their TVs. By the way, I haven't been in UHS in a long time, so if Jerry Springer is not anymore there, I apologize. But even I said, oh my gosh, that's horrendous. And then the patient will start talking to me. Oh yeah, but the action, the using, it doesn't matter. That's interaction. We disagree, but we are talking. The patient is explaining, engaging. You see my point? That's what we all of us should do in changing the culture. So with age, there are more changes in everything. When you get old, your muscles weaken, your reflexes weaken, your blood pressure control is very labile, your blood is crazy, so it makes you feel you need to go more often. Your skin, not even talking about all the creams that I buy every day. Nutrition, cognition, right? So the idea is that we need to improve all of these bad things on the left. What are the best practices? Avoid the bed rest, avoid the restraints, theaters, establish protocols for ambulation, use the restorative aid. You don't need to have therapists, are precious people, there are not many. So they really need to be allocated for your most complicated cases. A good restorative aid can train the CNAs to do a very good early mobilization. Feeding, toileting, basic stuff, that's what we do in the ACE unit. Eat meals on a chair, not in a bed. If you have a recreational therapist, that is fabulous. Involve the family. You're part of the team. You're going to be my pair of eyes. You can sleep in the ACE unit. The patients can sleep with their families. So the family become a nurse. Well, my mom is acting weird. I think she does this when the blood sugar is coming down. You bet that they know. They live with them. My mom is acting out. Something is weird. Can you check me? Oh, she wants to go to the bathroom. Can you help me? Use the family as another part of your team members. How are we doing in time?
You've got 20 minutes if you want.
Oh, 20, no, we're doing great. 6, fall prevention. What are the best practices in falls? So falls, people having postural changes. So that's the reason that they stand up, but they usually don't fall immediately. They walk with the walker, and 2 minutes later, boom, on the floor. It's a delayed response, so we call that postprandial hypotension, orthostatic hypotension. They sometimes get dizzy. Pay attention to those dizzy spells because that can get into trouble an older adult. There is less water retention, a lot of bone loss, so that's the reason they break their hips or their arms or fragile vertebrae. Bed rest makes them worse. More or less in geriatric, we said, for every day that you are in bed, it will take you 3 days to get better. So take seriously when you have an elder and they are 7 days in the hospital without getting up. And these days, Medicare is going to start cutting down their 20 days of skill time. So again, moving them, simple mobilization. And if you have a demented bedbound patient, passive rate of motion. You know, if those joints get contracted, they are painful. Putting their pillows, moving them around, their skin gets better. So there's a lot of things that you could do even with somebody that is not very mobile. So what do you think will be best practices for falls preventions? Let's see, who has been quiet and I will go nearby. But what do you think? Okay.
Remove all the clutter, make sure they're in a safe environment.
Very good. You went to, he's one of our great social work fellows, and so she went to all the first training in geriatric, so in palliative care. It does exactly, move the clutter. So if the patient is at home or in the hospital, you want them to have no clutter, no boxes, no too many things. What other things do we put in patients that can make them fall? What kind of devices do we put on them? The tubes. Think about that. If you have a patient with a PEG tube, a Foley catheter, big lines, central lines, and they need to be mobilizing, that is a challenge. So we think, do we really need that PEG tube? Do we really need that big line? Do we really need that central line? Do we? Every day, if I'm a nurse, I usually train my nurses. Every time you enter the room, gosh, I need to call the doctor. Do we really need that big line? Or it's time to take it? Even if you know it's going to stay there for a long time, ask the question, is there anything that I can remove from the patient? Right? Very good. What else? I'm sorry? Lighting. So many others, especially when you discharge, you want light in the evening. So you want the one that probably turn on by itself, so you have a night light, but they have visual impairment, glaucoma, usually macular degeneration, they have presbyopia, and then you add them, they are weak, and then now they need to toilet, and if they don't have a good light at night, that can be a problem. So what nurses do these days in the hospitals every hour? And that has improved some. Again, no one strategy helps with this. It needs to be a multi-intervention. That's very important. Because again, these people have multiple problems, you cannot fix the thing. So the nurse going, be kind, checking, are they awake, are they sleepy, are they toileting, do they have any need, can they reach their button, are they demented so they cannot reach the button because they don't know how to operate that. All of those things need to be present in people around them. So what the best practices are hourly rounding with the 4 Ps. Personal needs, pain, position, possession, and toileting program. So instead of asking a patient to tell us when they toilet because they are demented, we put them in a scheduled toileting. So we go and ask the patient, let us go to the bathroom. Instead of, do you want it to urinate? It's let us go. So invite them to, because those are the high-risk falls when they wanted to toilet by themselves. Letter rounds and concurrent audits. So there is a lot of patient safety nurses that do that. They audit that these things are being implemented. That the bed alarms are actually working and using appropriately. Switch from high gloss to low gloss wax floor. So that's a huge intervention in AC units. The environment is much more home-like, it's warmer, there is reduction in noise. And I don't know if you have it, when I drive in San Antonio and there is too much light in rain, you cannot see. The reflection of the rain is really bad. The same happens with elders in hospitals or in places that have really glossy floors. So I have a story for you. There is a little nun that fell down here in San Antonio in one of the nunneries, and she broke her vertebrae. So we met with the superior, the mother superior, and they take pride. The glossy the floor is, the best. And they have a high risk of falls. And it was really hard for them to understand the high, glossy, slippery floors, and they care for all of these senior nuns. Needed to change. And again, they did it with their hearts because they're very clean. But they needed to make changes, and they decided to modify the flooring and do something more without glare. So simple thing like that, finding out where the patient lives. Many of our seniors in the south side, the houses are 90 years old. And if you do home visits, you are checking where you don't fall, and they have the 10 cats and the dog and the newspaper from 1930, and then you see what I'm talking about. And then the houses are like this, so you're like, oh, it's going to follow me. So you have real challenges, right? And I cannot say enough about meds. What happened with my red thing? Here. Review meds and meds. Remember our little lady? What was the medication she was taking at night? Hypnotics. So all of your ambience, your, I don't use that stuff very often, Lunestas, I'm sorry, I should be using generics, so I apologize for the CME people. All of the generics are there. Why? Because that is an easy fix, you see? Be honest, you know, you're a nurse, man, this is the end of your shift, this is the little guy every night, coming and moaning. Much easier sometimes to ask for a pill. The best models of care include a lot of sleep hygiene, use aromatherapy, lavender, using a decaffeinated drink like chamomile, using music to induce sleep. It's okay for you to have some sleep deprivation when you're in a new environment. Stay away from the hypnotics. The data shows that these medications will make you fall. So when we introduce what we call the sleepy box, which has all of those things, the music and the decaffeinated tea, and you tell the family, you know, to bring, it's like when you put a baby to sleep, you know, you prepare them. All of you have a routine to sleep, I hope. The majority of you, confess, tell me here, do you have your routine, right? So the same thing when you're in the hospital. Can you induce the sleep in a way that is much more natural than trying to force it by the medication? If you take a benzodiazepine, meaning lorazepam or Ativan, you are 28 times more likely to fall than if you are not. So check those meds. What else are you using? Can you remove something? I'm not telling you that if you have been taking, you know, lorazepam for 50 years, you're going to stop it in the hospital because you bet that patient is going to withdraw and fall. What I'm saying is raise the question. Is there anything that we could do that is not aggressive? So we need to move on, but there are also a lot of stuff in toilet and falls. And toileting program, again, bladders are a problem. So don't forget the bladder, poor little organ in the body. This is one of the reasons that people also fall. We have more little cramps in the bladder. We feel that we need to go more often. The capacity of the bladder is reduced. So avoid unnecessary catheters. If you need to use them, do a good job by doing the aseptic technique and follow the protocol. Mobilize earlier then. It's much better to put a commode if you need it. Again, if the patient used to go to the bathroom, I will try to take them to the bathroom. Avoid the commode. Again, it's an issue of retraining quickly the body to do what they used to do. Now, if they cannot do it, you know, but try to think about, do I really need to do this intervention that will decline their functional status versus doing what they were doing before? And that's a balance. That's the reason you need the teams. Skin integrity, all of you also know this. Again, we have 5 minutes, so I wanted to be sure. Be sure, again, you have a comprehensive assessment. I know all the hospitals do, because it's a Medicare never event. You develop a pressure sore stage 3 or 4, and it's preventable, and get paid. Nursing homes also decided to buy pressure relief mattresses. It's much more inexpensive to buy them that don't get paid for one in stage 3 that needs a graft. Care planning, use technology. There is tons of technology. The VA also has one of the best access to get better technology for that. Nutrition, I love that you mentioned nutrition because it gets usually run down. But you need to eat good. Usually when you are elderly, you don't have teeth. I love that you point that out. Many people don't point that. If you don't have teeth, the availability to chew certain foods decreases. Your smell and your tastes decrease. So we tell that patients in dementia that are having swallowing difficulties and they pack it, add a little bit of Tabasco, add a little bit of pepper. That triggers the swallowing. Increase your salt if there are no contraindications. Put more sugar on it. All of that can help swallowing. Simple interventions that can improve compliance. Simple things that I ran a nursing home for years. That's what we did. And we did dental care in the nursing home, and our Gero Dental from the geriatric group will come and help us to do dental cleaning and teach my staff how to do dental clinic and dementia. There is clear data. Listen to this. That's the reason you need to brush your teeth, okay? Pay attention to this. I tell this my kids. If you have good hygiene in these elders, especially in nursing homes, their aspiration pneumonia decreases. Simple thing. Putting xylitol. It's a film that is in some of the lollipops and gums that you chew. Xylitol is a great film for Zephyr. Simple thing that you can do in the nursing home. So geriatric dentistry has started becoming more relevant because now we have data that if you don't aspirate because your mouth is clean. And I love when my kids, I take them to the nursing home and they see all of these patients without teeth. That's what happens when you don't brush your teeth. They got it. Yeah. So, early recognition of the loss of appetite, identification of weight loss, cultural competent diets, address dysphagia, all of the things that are just important. And I always think about when the families are like, oh, my mom is 95, but no, I don't let her eat pan dulce. I'm like, 95 and I don't let her eat pan dulce? Eat pan dulce. Liberalize the diet. They are eating very little. The only thing that they eat is pan dulce. Go ahead and eat pan dulce. You're 98. Am I going to take away the pan dulce? So they love it. They love it. I like that. I'm the doctor that don't believe in a lot of restrictions and diet with your own. There are very few things they have left. Food is one of those. Okay, hospitalization and cognition. Delirium, big problem. This is all of your patients are going to be predisposed. Every single one that you admit. And because I'm running out of time, please check this protocol. So the best protocol is a standard of care developed by Sharon. Every hospital should have this implemented by now. It's a standard of care. It's proven data. Elders that get protocols for sleep, mobilization, visual impairment, hearing, and dehydration. If you tackle those things, you're not going to see as much delirium in your units. So check that again. You have the slides. Those are the ACE unit in Santa Rosa. We have a walking little simulation area, so our patients go. They can play grocery shopping. They can walk around. They have a dining area or restorative aid. Move them there. We have developed a bilingual delirium prevention protocol that is followed by nurses. The pain communication board, who is your nurse, all of these things, and we actually involve caregivers to help us to do the language, and they can help because they will read this and, oh, I need to bring the glasses for my mom. So the nurse not only check if they are visually impaired, but you are asking them to bring the glasses. That's a big difference. I know all of you ask if they are visually impaired. There is a very different point when you are sure they have their glasses, okay? Are you hearing impaired? Yes, you check the list. Are you checking constantly and using a packet talker, an amplifier, their hearing aids, whatever you wanted to put in place? Okay, do a good job. Love your patients. You're doing wonderful. But there is always better options and opportunities to do even better. That's where we need to be. It has been a pleasure to be with you. I will take a question or two and then we can close the talk. Any question, comment, concern? I take a sponsorship too, so you wanted to write a check, I take it. Okay, well good, thank you so much guys.